Next is colorectal cancer V1 anal carcinoma. A 70-year-old man presents to your clinic with a painful ulcerated anal lesion. The appearance are suspicious for an anal carcinoma. There are some enlarged inguinal lymph nodes in the right groin. Clinically, how would you manage the patient? I would do a complete medical history with performance status assessment, asking about anal pain, bleeding, discharge, and is he any trouble in bowel opening, history of anal intercourse, genital warts in history, or HIV history. Then we'll examine the patient, feeling for regional lymphadenopathy, hepatomegaly, inspect the anal region. It is important to differentiate between the tumors in the anal canal versus those arising from the anal margin, because small lesions at the anal margin may be treated by surgery alone, unlike the true canal tumors. Anal margin lesions look like malignant ulcer with raised, everted, indurated edge. Anal canal lesions may not be visible, may be painful on peer examination, and may have rectal extension. Perirectal lymph node may be palpable. I will reach the patient for urgent EUA, rigid scope and biopsy. At EUA, I will assess the tumor size, involvement of the local structures, and perform a biopsy. I would also arrange an FNA biopsy of the anal lymph node, because 50% of the enlarged anal lymph node will show evidence of METs, while the rest are enlarged due to secondary infection. Finally, I would request an MRI to assess the extent of the local disease, and CT scan of thorax, abdomen, and pelvis for distant METs. Biopsies confirm a squamous cell carcinoma which on EUA is extending into the anal canal and is 3 cm in maximum diameter. What would your management be? I would have a patient will be discussing anal canal cancer MDT, and if they recommend, we will do the PET CT, and I would refer for oncology opinion and suggestion regarding chemoradiotherapy. So high dose radiotherapy in 2 courses, and IV5 fluorouracil and mitomycin. Superior local control from the combined therapy over radiotherapy alone. Complications of chemotherapy include diarrhea, mucositis, myelosuppression, skin erythema, desquamation, and stenosis, and anal fistula formation. I would confirm he has had his HIV test as well, and I will confirm that he doesn't need any defunctioning stoma. How do anal cancers spread? Locally, they spread so they can appear to be originated from the rectum, outward invasion into the local structures, rectovaginal septum, perineal body, scrotum, and vagina, to lymph nodes, perirectal lymph nodes, followed by inguinal, hemorrhoidal, and little pelvic nodes, and late hemorrhage spread into the liver, lung, bone associated with advanced local disease. The patient has a complete response initially, but at 12-month checkup, he has an ulcerated lesion at the site of the previous ulcer, suspicious for recurrence. What would your management be? So repeat EUA, biopsy, and biopsy needs to be of sufficient size depth to differentiate from the post-radiotherapy change. If there is no METs on restaging, including CT, MRI, and PET, the patient should be considered for salvage abdominopelvic resection. If it's involving the vaginal and rectum and catheterization can be obtained, he can be candidate for pelvic excision depending on the fitness. Thank you.